The heart is a pump. It has a top and a bottom and a left and the right. The top of the heart, the roof of the heart or the atria, is the receiving chamber of the pump. The bottom of the heart, the ventricles, are the pumping chambers which pump the blood around to the lungs and around the body. The heart's an electrical pump. It receives its signal to contract from a pacemaker at the top of the heart. And imagine this a bit like a stroke in a rowing boat. And following on from the stroke are hundreds of thousands of rowers all beating in synchrony. So the stroke sets the rhythm, and this spreads electronically through the top of the heart. The top of the heart then contracts, and the blood goes from the receiving chambers, the atria, into the ventricles, the bottom of the heart. Now, the top and bottom of the heart are separate electrically, and therefore the impulse from the stroke can't get through. However, luckily there is a junction box called the atrioventricular node, which takes the impulse from the pacemaker or the stroke and transmits it to the bottom of the heart. This then contracts and forces the blood through to the lungs from the right side of the heart and the body from the left side of the heart. And this is the cardiac cycle of the pump. The receiving chambers receiving the blood, the pacemaker setting the rhythm, the atria contracting, the blood going through to the bottom of the heart, the junction box transmitting the signal to the bottom, which then contracts. The heart has lots of very clever backup mechanisms. So if the stroke fell out the boat, if the pacemaker stopped working, the heart wouldn't stop beating. Every single cell in the heart, every single rower, has a potential to set a rhythm on its own. And for that reason, in all of us, occasionally we'll get an extra beat, just because it can happen. One of the heart cells will contract and send a rhythm through the heart. This is what we call an ectopic beat. This may start at the top of the heart from the atria, that's called a supraventricular ectopic, or it may start in the bottom of the heart, that's called a ventricular ectopic. Now, in atrial fibrillation, imagine there's a group of rowers at the top of the heart who are ignoring the main stroke and are just rowing independently. As they row independently, they bump into each other and then bump into the cells around them, and a chaotic rhythm ensues in the top of the heart. All the rowers then start rowing independently. The top of the heart, the atria, are wobbling about, and that's what we call atrial fibrillation. They're beating very fast and very erratically. Now, if the bottom of the heart did that, you'd be in trouble. But luckily, this is when another protective mechanism comes into play. Remember I talked about the junction box, the AV node. Well, that can only transmit a certain number of signals through, and that slows down the chaotic impulses from the top. So the bottom of the heart still beats irregularly, but a much slower and sustainable rate, usually a bit quicker than usual, perhaps 120, 130 beats a minute, as opposed to your normal 70 beats a minute. This rhythm isn't dangerous. It doesn't cause heart attacks. The main problem is when it's happening, it can set up eddy currents in the top of the heart, like in a pond. And when the water or the blood's circulating around like this, it can form clots. And clots go north to the brain, and this causes a stroke. Luckily, we can treat atrial fibrillation. We can give medication to sedate the rowers, make them a little bit less excitable, and make them less likely to go into their chaotic rhythm. This is called anti-arrhythmic medication. Alternatively, we can burn a firewall around the rowers. This is what we call ablation. We can isolate them, so even though they're beating erratically and independently, they don't change any of the cells around them. They don't affect any other rowers in the boat. So the rest of the heart contracts and beats as normally. Alternatively, we can do what we call a rate control strategy. We can give medication to slow down the transmission at the junction box. So although it's still beating irregularly at the bottom, it's beating at a slower and more sustainable rate. The most important thing we do, though, is to assess your chance of a stroke. And we have ways of doing this. And if we think the risk of a stroke is considerable in a patient with atrial fibrillation and it's not significant in everybody, then we can give medication to make the blood less sticky. This is what we call anticoagulation and is incredibly effective at preventing strokes. Sometimes in atrial fibrillation, the heart cells at the top are setting this chaotic rhythm, which is bombarding the atrioventricular node, the junction box. But sometimes, especially as we get older or we have other conditions like hypertension or diabetes, this junction box gets less able to transmit the signal and it can become blocked, either intermittently or all the time. And this is what we call heart block. When this happens, and if you remember, I said any heart cell, any row can beat independently, then a rhythm starts at the bottom of the heart independent from the top of the heart. Heart cells at the bottom beat slower. Therefore, in this situation, the heart is beating at a much slower rate than usual. And this can cause breathlessness, dizziness, blackouts, tiredness, feeling faint. So what we can do in this situation, we can fit a pacemaker. This sends a separate electronic image to the bottom of the heart, telling it to contract. And we can set this to work at a much slower rate, akin to your normal heart rate. It's important to remember through all this, even though the top of the heart is beating erratically, it does still manage to send the blood through to the bottom of the heart. So in atrial fibrillation, the heart is still working fairly well, but not quite as well as in a normal rhythm.